A slightly more difficult situation comes up when only part of the joint is affected by osteoarthritis. And that is more common than we think. And that happens in the young patients. And these are the specific population who, if we do a knee replacement, they may not be so happy with it because they would like to do more. In fact, they are doing more. They are younger and they want to do more. So I'd like to bring a new concept in that I use in my armamentarium of treating the arthritis in the young, and that is the limb realignment surgery. So as we know, we stand with a normal limb alignment, and that is when we draw a plumb line from the center of the hip towards the center of the ankle, that should go to the center of the knee. And from there, there'll be variations on knock knees, where the knees touch each other, and we put more pressure on the outside compartment, the lateral compartment, or indeed the bow-legged people who, if you watch the Irish squad on singing the anthem at the match, the soccer squad, a lot of their players would have bow legs, and that is because they're good athletes, and people with bow legs have a better biomechanics with running, and they develop that way because they play sport for a long time. Now, that has huge implication in developing degenerative changes in one compartment. In other words, if in someone with bow legs, we take out the medial meniscus, much quicker the arthritis will set into the medial compartment. And in that setting, the realignment surgery, it comes as a very important weapon in treating osteoarthritis. So my ideal patient for an osteotomy, which is a limb realignment surgery, is, I call him the referee, okay? So it's always a middle-aged guy who's very active, who has played sports before, who may have had surgery, who may have had injuries, and he presents with a change shaped in his knee. And, you know, these guys are generally fit. They want to be involved in sport, and they're compliant with what we ask from them. And this is essentially what an osteotomy, it comes from the word osteo, which means bones, and otomy, which means cutting the bone. So essentially it means cutting the bone and realigning to balance the forces in the knee. This is, in fact, historically, this surgery has preceded the knee replacement surgery, but with the advent of knee replacement, with the industry promoting the knee replacement, somehow that became a lost art in the orthopedic community. And however, the Europeans have continued to do it, and it's an excellent joint preservation procedure in the right patient. And it essentially means to cut the bone, realign the bone, fix it with a plate until the bone heals in order to unload a specific compartment. And it could get quite technical, is technically demanding surgery. It takes a compliant patient to mind the osteotomy and the healing process that lasts about 2 months, to use crutches for about 4 to 6 weeks, and then to resume his activities. I normally remove the metal out at a year and a half, as it can irritate the soft tissues. As I say, the Europeans are doing a lot of osteotomy surgery, and I had a chance, part of the European Knee Society, to travel around the centers in 2017 to maybe develop a sub-specialty interest in this type of surgery. So the best way to talk about this surgery is actually to show you a few cases from my own experience. So this is the patient who has bilateral VARs. So it's bow-legged, is a 41-year-old, a GAA coach. And on the right-hand side, you have the MRI of his knees. So on the first row on the MRI, you could see the lateral meniscus is the black triangle. The cartilage on the outside of the joint is well preserved, it's quite thick, whereas on the inside, the white is the fluid that filled the lack of cartilage on the medial femoral condyle, medial tibial condyle, and you can see there is no medial meniscus, no black triangle, and the bone has a bit of bone bruising. And essentially that is isolated medial compartment arthritis that causing the symptoms. So when we started to draw the plumb lines in this patient, you can see that drawing a line from the center of the hip to the center of the ankle, rather than going through the middle of the joint, it goes through the to the middle of the joint, goes to the medial compartment. And that puts pressure, and he presented with pain, inability to walk, night pain, inability to train or to do his job. So ideally, you want to bring that line through the middle of the joint as is illustrated there. And to do that, you need to change the angle of that by about 7 to 8 degrees. And that is essentially what I have done. I have used a saw and perform a control cut under imaging on his proximal tibia and fix it with a strong plate, and then secure it with plate and screw. And this is the X-ray at 3 months when it started to heal, and this is where I have brought the mechanical axis of his leg. So if you look at the clinical picture, you could see the right leg under the kneecap, you could see his incision, and you can see that the leg is not bowed anymore. In fact, it looks as if it's brought into a slight valgus, about 1 to 2 degrees. In other words, he is putting most of his weight on the outside compartment that has good cartilage and good meniscus. On the other side, I want to show you an example of the lateral compartment arthritis, where the patient presented with a knock knee. And this is a guard who is 51, and he had a lateral meniscectomy where the lateral meniscus was taken out. And like the previous patient who had the medial meniscectomy, this guy developed severe arthritis isolated to the lateral compartment. So if you watch this video, this is how he walks.
Okay.
Yeah. You can watch his right leg, and as he turns around, he's bringing the leg in, overloading the lateral compartment, and therefore having pain at night, not being able to perform his job, and really being in pain. Now, this guy has failed all the treatments such as injections, braces, and he really wanted something done about it. So again, when we looked at the 3-foot standing films, when we get an X-ray of the whole limb, lower limb, and we draw the mechanical axis, you could see in the left knee, it's slightly off the medial side of the knee, and that is his normal alignment. On the right knee, however, you could see it's almost not touching the joint, the plumb line, and that's severe valgus alignment. So in this patient, rather than doing correcting the deformity on the tibia, we do it on the femur, and the deformity is about 9 to 10 degrees. And this is what we do for this patient. We cut the femur, and we either open the lateral side or we're closing the medial side and fix it with a plate. So in his case, I inserted a wedge, a bone graft wedge on the lateral side, and I fixed it with a plate, with a strong plate to support the osteotomy until it heals. So you can see when I repeated the X-ray after the surgery, I managed to bring the plumb line, the mechanical axis, exactly in the same place where it was the normal side. So I saw this patient last week. He was 9 months after surgery, and he was absolutely delighted. He was walking, he was exercising, and this is a clinical picture of him beforehand, if you remember. And you could see the right leg is in knock knee, is in valgus, and that's after. And this is a normal knee alignment. Of course, he has a bit of muscle bulk loss, muscle wastage, which we are still continuing. And I booked him last week for removal of the plate at 15 months after surgery, as the plate sometimes could irritate the soft tissues. And this is a more extreme patient when it shows the importance of this powerful surgery, the osteotomy, in a long-standing ligamentous deficiency. And every now and again, we see patients like this. This is a patient who is only 48. He was sent to me from another surgeon. He unfortunately had a severe ski injury many years ago when he damaged the lateral collateral, and he did nothing about it. Interestingly, he not only developed the right knee arthritis, but he developed the contralateral left hip arthritis, which was affecting his quality of life significantly. So firstly, I treated him with a hip replacement, and he did well with that. And then I treated him for the knee. He was proposed by a different surgeon to have a right knee replacement, but he felt he was quite young to go ahead to have a knee replacement at the age of 48. So that's him. My patient standing, and you could clearly see the deformity on the right leg. That is significant tears. And you could see him walking here. If you watch the right leg, that's called what we call a varus thrust. So he is throwing his leg out as he walks. So this is him looked from behind. Now that is a significant deformity. That is a significant varus deformity. And obviously it's getting worse with time. And when we did the similar analysis of his lower limb x-ray, this patient had a 16 degrees deformity. And he needed a huge correction to address that. And that probably happened because he was deficient in his lateral structures. So every time he walked, he was throwing his knee out. And for this patient, I did a high tibial osteotomy where I opened the leg and realigned his limb to be neutral. And I use a 18 millimeter bone graft, which is quite a significant opening, and fix it with plate and screws. So you could see on the left side how he was before the surgery. On the right side of your screen is how it is now, with his left hip being replaced and his mechanical axis corrected pretty much to neutral. And this is him now, a year after the surgery, and you could see the alignment on the right leg is corrected. And if you watch his right leg with the sock, that's the limb that has been operated on. That's now how he walks.
And come back.
So he's not throwing his knee anymore, and he's not wearing the medial compartment. So he's running on his well-preserved lateral compartment. The other partial joint preservation surgery that we do is the partial knee replacement. And in some patients who are older, such as this patient who is 70, who's active playing tennis, he presented with excellent lateral compartment. You could see the lateral meniscus, the big black triangle, the cartilage is very well preserved. Whereas on the medial side, the medial meniscus is macerated, the cartilage is worn. And I had treated this patient with brace, with injections. I even have done an arthroscopy to remove some of the meniscus, but he was not getting any better. And after about 18 months of conservative treatment, we decided to, based on those x-rays where you clearly see on the right knee that there is no space on the medial compartment, is well-preserved space on the lateral compartment, then we did a partial knee replacement. And that is joint preservation in a way that 2/3 of his joint has been preserved. And that will make his recovery much quicker, much easier comparing it with a knee replacement.